So shall we start?
Start. Kitty, hi.
Yes. So we'll start, sir.
Mhm.
Hello and welcome everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own onco savior, Dr. Krishnamani, to spread awareness about cancer and help patients and caregivers access the right treatment at the right time. In today's live session, we'll be diving into a topic that's reshaping the way we understand cancer risk and the treatment by BRCA1 and BRCA2 mutations. These are more than just genes. They are key players in the early detection, prevention, and management of cancers. But with so much information out there and even more myths, it's crucial we separate fact from the fiction. To help us navigate this important topic, we have with us a leading medical oncologist who will shed light on what BRCA mutations mean, who should be tested, how it affects the treatment choices, and what options are available for individuals carrying these mutations. Without much further ado, let me begin by introducing our doctor to you. Dr. Krishnamani has extensive expertise in managing a wide range of cancers, including both solid tumors and hematological malignancies. He is well versed in delivering advanced treatments such as biological therapy, immunotherapy, and he is skilled in managing oncological emergencies also. He has been actively involved in academic contributions and professional development, participated in numerous seminars and meetings, attended over 25 or more workshops, and presented papers at both national and international scientific forums. Currently, he is associated with AOI hospitals here in Hyderabad since the past decade. Hello and welcome to you, sir.
Hello and welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness on cancer. Thanks for the introduction. And today, as you said, we'll talk about cancer and BRCA1 and BRCA2, or as we call it, BRCA1 and 2.
Yes. So, sir, can you help us understand what are these BRCA1 and what is BRCA1, what is BRCA2 gene?
So, to give you a basic understanding or a historical perspective, so people have breast cancer, which is a very common cancer, and also ovarian cancer. We see sometimes that breast cancers or ovarian cancers are clustered in families. That is, many people across the generation have breast cancer. A woman may have breast cancer, her sister would have had, her mother's sister, her cousin, first cousin. So this is the familial cancer. Okay, that is, there is a family history rather. So when you have a family history, the initial, as a common man, what do you and me say? Sir, something genetic. Okay, so 10% of breast or ovarian cancers could be genetic or hereditary, in which the commonest gene which is involved is BRCA1, BRCA2. One is BRCA1, one other is BRCA2. Okay, now you talk about lung cancer, for example. Common causes are smoking, acid smoking, asbestos exposure, etc. When you talk about breast cancer, genetic, so in lung cancer, the amount of genetic causes leading to lung cancer are very few. On the contrary, talk about breast cancer. 80-90% are sporadic. That is, we don't know the reason. It is because of hormonal changes, early menarche, late menopause, nulliparous women who do not have children, women who do not breastfeed, taking oral contraceptive pills, etc. But you cannot pinpoint that this is the reason. But in 10% breast cancers, you can pinpoint that you have a genetic problem, you have hereditary issue, you have a gene which is mutated. The name of the gene is BRCA1 or BRCA2. You have breast cancer because of this. Now you will tell me I have breast cancer because of this gene. So what's the big deal? The big deal is for the patient, you have certain medications like positive cancer. Platin is cisplatin carboplatin chemotherapy. There are medicines which target BRCA1, BRCA2 called PARP inhibitors. The names are drugs like olaparib, rucaparib, etc. So for a patient, you are diagnosing they are having the mutation. So that is the cause of their cancer. There are medicines for that. Imagine that is number one. After you diagnose it on the patient, you will diagnose it in the first degree family relative. That is, you will sample their blood. If they are positive, you are going to take precautions for them to prevent cancer. So imagine a mother has breast cancer. You have done treatment. You have done the BRCA. She is BRCA positive. You will test her daughter. If the daughter is BRCA positive, this daughter still has not got cancer. So based on her BRCA, she has a risk of breast cancer, ovarian cancer. You have options to reduce the risk. To put it in a different way, the daughter comes to the OPD and says, sir, my mother has breast cancer. What should I do so that I don't get? So this is the way you test the mom, not the daughter first. You test the mom. The mom is positive, test the daughter. The daughter is positive, you say, see, you have a risk of breast and ovarian cancer. These are certain precautions. So that is the advantage one for the patient, and also these are the advantages for the patient and also for the kith and kin.
Okay, sir. So where are these genes located, like in our body? Where do you find them?
Beautifully, you have put a photograph for the image. BRCA1 is a mutation in the chromosome 17. BRCA2 is in the chromosome 13.
And
So because of this mutation, sorry,
sir, you please continue.
Because of this mutation, you have a risk of breast cancer, ovarian cancer, pancreatic cancer, prostate cancers.
If this is like the normal chromosomal structure, does it mean that every individual is having this genes in it on chromosome 17 and on chromosome 19?
Yes, and you have a risk of mutations because of various external factors.
Okay. So can you expand on the cancers which are commonly associated with the BRCA mutations?
Commonly four: breast, ovary, pancreas, prostate. These are the common cancers which we see in BRCA patients. Now, if you look at breast cancer, the risk is in BRCA1 patients or carriers, you call that. If you're a BRCA1 carrier, the risk of ovarian cancer is 55 to 65%, if I'm not wrong. In BRCA2, it is slightly less, maybe 40 to 50. So 50 to 60 in BRCA1, 40 to 50, the risk of breast cancer. The risk of ovarian cancer is in 10 to 20, 25%. The risk of pancreatic cancer is slightly higher in BRCA2, but it is in single digits, 5 to 7%. Prostate cancer is 5 to 10% risk. So the carriers have an increased risk. This risk is over the general population. Suppose this BRCA carrier is compared to a general population, normal person, this fellow has a 50 to 60% risk of breast cancer, 20 to 30% risk of ovarian cancer, 1 to 5% risk of pancreatic, and 5 to 10% risk of prostate cancers.
Sir, is it true that the BRCA mutation can jump generations and be present in alternate generations also?
What happens is, it could happen. It could happen. You will test the patient first, and only if the patient is positive in the blood, that is called a germline mutation, you are going to test the family members, the kith and kin. You also test the BRCA on the tumor, which is called a tumor BRCA. Somebody has a tumor positive for BRCA and the blood is negative, that is a somatic mutation. That is, this patient has developed a mutation in the tumor, but he or she doesn't carry it in the blood.
Okay,
So
sir.
a blood test is done, that is germline BRCA, and a tumor mutation is done, which is called tumor BRCA or somatic BRCA.
And sir, who should ideally be undergoing the BRCA genetic testing?
This is the most important thing. Any woman with ovarian cancer, do BRCA testing. Anybody with metastatic prostate or pancreas, do BRCA testing. Nowadays, they say any woman with breast cancer also do, but otherwise, below 65, if a woman develops breast cancer, do BRCA. If you have a variety of breast cancer called triple negative, do BRCA. If you have male breast cancer, men develop breast cancer, remember, do BRCA. If you have multiple family members, first degree or second degree, do BRCA. If you have bilateral breast cancer, do BRCA. If you have breast and ovarian cancer, do BRCA. So, summarizing, women below 65 with breast cancer, women with triple negative, men with breast cancer, women with bilateral breast and ovary, only ovarian cancer, metastatic pancreas, metastatic prostate, do a BRCA.
So the next thing I want to ask you is that if a family member has tested positive for the BRCA mutation and you're advising the test to the next kin, then ideally, how often should the members be tested for the BRCA mutation?
Not how often, only once.
Only once. Okay.
You test my blood. If my blood is BRCA positive, I am BRCA positive. If I am negative, I am negative.
Okay. So, sir, how does the presence of a BRCA mutation influence cancer screening or surveillance?
I'll give you an example. We had a gentleman with pancreatic cancer. We gave him stage 4 pancreatic cancer. We have been treating him with chemotherapy. Elderly man, 10, 12 cycles, chemo, hard chemo, completely down because of side effects. We told the family, let's do the BRCA. Okay. We send the tumor. The tumor is positive for BRCA. Then we send his blood also. Blood is positive for BRCA. Then we put him on a tablet called olaparib. Okay. It is 3.5 years. He is fine. Pancreatic cancer survival stage 4 is less than 9 months to 12 months. 3.5 plus initial 7 months of chemo, 4.2 years, he is super fine. Number one. But what I'm trying to tell you is you were able to identify a mutation in a hopeless case, hopeless cancer, and that person is surviving extremely well. And the chances of BRCA coming positive are not high in pancreatic, it's actually high in breast and ovary. Okay. So in those patients, it will do even better. Now we tested his children, one daughter, one son. Both are BRCA positive. So why I'm coming to your giving you this long explanation is you asked me how you are going to follow these people up. So the son is also positive, daughter is also positive. So son has a risk of male breast cancer, prostate, and pancreas cancer. So we will we will do mammograms for him once he's 45, 50. We do a PSA for him every year. We do an ultrasound abdomen once and do a blood test called CA 19.9 for pancreatic cancer. For the daughter, you offer two things. If the patients, if the carrier, if the lady carrier, okay, the BRCA woman carrier has completed family, has completed children and all that, between the ages of 35 to 40 or 40 to 45, you advise them to remove the breast, which is called bilateral prophylactic mastectomy. Bilateral means both sides. Mastectomy means removal of the breast. Prophylactic means you are doing it so that it is like removing the organ before you develop a problem. That is prophylactic. Now I'm wearing a mask. That is like prophylactic so that I don't catch a cold. So bilateral prophylactic mastectomy and also bilateral salpingo-oophorectomy. That is the fallopian tube and ovary is cut. You need not touch the uterus. Why? Ovarian fallopian tube cancer risk is reduced. So father had pancreas. He is on a medicine. He is doing well. For daughter, she has a risk of breast and ovary. So for the breast cancer risk, which is 50 to 60%, you're removing the breast. For the ovarian cancer, which is 10 to 25%, you're removing the ovaries and fallopian tube. If she doesn't want it, now there are women who may say, I don't want to remove my breast. Then annually you will do an MRI and a mammogram of the breast. 6 month, first you will do a mammogram. 6 months later you will do an MRI of the breast. And if you detect something, you will treat it. Or for this, you may just do this. And ovaries, they may say, okay, I have completed family, I'm ready. So you remove the ovaries and fallopian tube. And once you remove the ovaries, there is some help for the breast also. The hormones come down. So it indirectly helps to reduce breast cancer risk also. So your options, ideal option is mastectomy, salpingo-oophorectomy. If you cannot, do screening MRI and mammogram of the breast. Or there is something called chemoprevention also. Sometimes we put these patients on tablets called tamoxifen, which will help reduce breast cancer and ovarian cancer risk. So in this example, so we know in whom we have understood in whom we should test. That is the patient first. If he is or she is positive, you test in the kith and kin. If they are positive, what are the risks? How do you use the risk? How often do you scan them or screen them? These are all the things which we have covered.
Sir, when you are diagnosing for BRCA1 and BRCA2, is the tumor biology different if it is BRCA1? Is it different if it is BRCA2? And consecutively, based on that diagnostic report, will the other parts of the treatment also change?
No. Yes, the tumor biology differs a bit. BRCA1 and 2. BRCA2, you see more of pancreatic cancers. I told you BRCA2, you see disease at a later age. That's why the risk reduction is, for example, the oophorectomy and the you call it RRSO, risk reducing salpingo-oophorectomy. In BRCA2 carriers, you do it at a bit later. Here, if you do it at 35 to 40 years in BRCA1, in BRCA2, you do it at 40 to 45 years. And the risk is definitely low, obviously, right? Breast cancer risk is low in BRCA2 compared to BRCA1 and also ovarian cancer risk, but pancreatic cancer risk is slightly on the higher side.
Sir, do the BRCA mutations affect prognosis of the cancer which is being detected?
Obviously, right? It affects the prognosis, it affects your diagnosis, it affects your treatment options. And next in kin also, no? It has so much importance.
Yes. So now the next part would be like, how is it affecting the treatment choices for the patient?
We discussed that just now. So if you are BRCA positive, today you are given these PARP inhibitors. PARP inhibitors are either given in the stage 4 setting or in the adjuvant setting, that is after surgery. So this is in adjuvant setting, you give it to reduce the risk of recurrence. In stage 4 setting, you give it to reduce the risk of progression or death.
You have spoken a lot about these PARP inhibitors. Can you explain how they are effective in BRCA mutated cancers? How do they work specifically to guide the BRCA mutation?
So in BRCA, what happens is PARP inhibitors work with a mechanism called synthetic lethality. They work with a mechanism called synthetic lethality. So with that mechanism, what happens is those patients who have BRCA are exquisitely sensitive to these PARP inhibitors, and the downstream effects don't happen in the cancer cell, and this leads to cancer cell death. That's why these medicines help in patients who have BRCA mutations by killing the cancer cells.
Are there any specific chemotherapy agents that work better in BRCA positive cancers?
Platins, we spoke about it. Carboplatins is platin. Again, they also work in the same mechanism of synthetic lethality, which causes breaks in the DNA and kills the tumor cell.
So, like, what are the preventive options for individuals with BRCA mutation? Like you said, one of it, I think you have covered, saying that we can get the breasts removed, but other options, other such preventive options.
bilateral prophylactic mastectomy for breast cancer. Risk-reducing salpingo-oophorectomy to prevent ovarian or fallopian tube cancer, but you can still develop peritoneal cancer. Remember that. You can still develop peritoneal cancer. Third, you are giving chemo prevention, drugs like tamoxifen, so that these patients don't develop breast cancer. So these are 2 or 3 strategies. And regular screening in the form of breast MR, breast mammograms, and PSAs, ultrasounds, and CA 19.9 for pancreatic cancers.
Okay. And so, like, in your day-to-day clinical OPD that you see the patients, typically, how do these patients who just recently received the knowledge that they may have a BRCA mutation, how do they cope with this knowledge of carrying the mutation?
You should do a very good genetic counseling. You should talk to them, sit with them, explain to them in detail what it is and what are the advantages. That is the whole reason we are having this episode also today. So those patients who are BRCA uh, will probably get a lot of knowledge on what treatment options they have, what risks they should take, risk measures they should take, risk reducing measures they should take, and also implications for their family. Also, there is something called BRCA-ness. BRCA-ness means clinically this patient is behaving like a BRCA positive patient, but the BRCA 1 and 2 is not detected. So they behave very sensitively to platinum chemotherapy. They have family history, but you don't detect the gene.
Okay. So now coming to the last part, which would be the myths and the facts. So the first myth is that only women get BRCA-related cancers.
No, we spoke about it. Men can get male breast, prostate, pancreas.
A negative BRCA test means you're not at risk for cancer.
You have cancer, your BRCA is negative. That means mutation causing cancer. Cancer is still there in the patient who has obviously cancer. Yeah. So BRCA is not
BRCA,
to diagnose cancer. BRCA is to diagnose whether you have a genetic cause of cancer.
that's where the next myth was coming from. So BRCA mutations guarantee that you will get cancer.
No. The risk is there. Reduce the risk with these measures. How much is the risk? We have already described.
And so the last myth is that you only need testing for BRCA mutation if you have a family history of cancer.
No, we listed out 8 people or 8 types who would need BRCA testing. Male breast, bilateral breast, breast ovary, metastatic pancreas, prostate, triple negative, family history, and women with less than 65 years of age who have breast cancer.
With this, we are done with bursting the myths for today. So would you want to give a summary of it, a short snippet of the entire session for our viewers?
So BRCA 1 and 2 is very common. It has to be tested. We spoke about, we do a lot of testing of this BRCA 1 and 2 in breast ovary cancers, and nowadays prostate and pancreas is also picking up. You do it in either in the blood, which is germline, or in the tumor. And if you don't test the relatives first, you test the patient first. If the patient is negative, you don't need to test the relatives. If the patient is positive, you test the relatives. If they are BRCA positive, you are going to take precautions for them. This way, they can prevent certain cancers.
So we have heard about a second opinion campaign which you have started. Can you elaborate about it for our viewers?
So in Cancer Reach, we believe cancer information reaching each and everyone. We have a second opinion campaign. It's free of cost. Patients have a WhatsApp number to which they can send their opinions. And we will try our best to give them an opinion on WhatsApp, on a message. So this is so that, and this is from a oncologist perspective. Qualified medical surgical radiation oncologist would be involved in giving you the opinion. It is free of cost, let me emphasize. And this is purely from a Cancer Reach perspective, where we want patients wherever they are across India to get an opinion so that they can continue their treatment. So they could be in places where they cannot get an oncology opinion immediately. So we want to fill in the gap there. so that if the word spreads and they reach out to us, we can at least guide them and what they can do forward.
This is a very novel strategy and a very novel campaign which is being run free of cost, which I hope a lot of people take advantage of and get tested or get the second opinion as early as possible from you, sir. Thank you for giving your time for today's session. Thank you for enlightening us on BRCA1 and BRCA2 mutations and the associated cancers with it. I hope this session was helpful and useful for everyone. Thank you, sir.
Thank you so much.